is to provide a brief perspective on the evaluation of resistant hypertension in clinical practice. I'll provide some definitions first. Failure to reach a blood pressure of below 140/90, or if you believe the patient may need a lower blood pressure goal, with at least a 3-drug regimen, one of which is a diuretic, and of course, all of the medicines that the patient is taking. Now, there are also going to be other definitions that we'll look at, but what I'd really like to share with you is the importance of the adrenal gland in causing hypertension. I think that's really the center of the problem after we have ruled out non-compliance. There are a variety of different classifications, and I think it's important to realize that we have to rule out improper blood pressure measurement, make sure that there are no obvious secondary causes of hypertension, appreciate the problems of salt, food, and alcohol. Another important issue that I will spend some time on is sleep apnea and obesity. And believe it or not, we're seeing more evidence now that obesity can lead to hyperaldosteronism, probably through visceral fat production of aldosterone. And of course, obviously, inappropriate treatment and failure to adhere to the regimen. Now, obviously, there are kidney causes. I'm not going to discuss those as secondary causes. I think the major ones to consider are the endocrine ones, and I'll really focus on mineralocorticoid excess, as well as sleep apnea, although there are obviously many other different causes of resistant hypertension. So let's delve into this issue of endocrine hypertension, particularly with the adrenal gland and sleep apnea. Now, we know all about the renin-angiotensin system. We tend to forget the second A, which is for aldosterone. But I think it's important for us to realize that there are a number of factors, as you can see here, in terms of how aldosterone can cause vascular problems at a target organ level. We also know it's quite common, probably represents 20% of all resistant hypertension in practice. And as an example of how common it is, in the Anglo-Scandinavian cardiovascular outcome trial, there were a total of about 20,000 patients. About 1,500 patients who were deemed resistant received spironolactone as a fourth-line agent. What's impressive are the blood pressure reductions shown here, both in terms of systolic and diastolic reduction. We're looking at net changes of about 20/10 simply by adding low-dose spironolactone as a fourth drug. I think it's important for us to appreciate this, not just for the numbers, but for the known molecular mechanisms of aldosterone vascular toxicity. And I've listed several of them shown over here. But I think it's important to realize that if we don't properly target this, then there will be an acceleration of the aging process in our patients. And there are a variety of hypothetical mechanisms for relatively high aldosterone despite low renin in hypertensives. And I've listed some of them here. I don't want to belabor all of the different pathways here because it's too much to cover in the time allotted. But I will focus on what I would describe as more common autonomous aldosterone production. And this, I think, is going to be particularly evident in people with obstructive sleep apnea and visceral adiposity. We have to remember, obviously, how aldosterone is formed. We also have to remember how cortisol is formed. And there are a variety of enzymes and genetic pathways which, if they are defective, can lead to excess production of either aldosterone or cortisol. What's fascinating is that people who are overweight specifically with visceral adiposity, as you can see here, whether supine or standing. If you have metabolic syndrome, as shown in the purple color here, you can see how much more common you have increases in plasma renin activity. And obviously, look at the differences in terms of reductions in plasma aldosterone. So there is something wrong about people who have visceral adiposity in terms of how it alters the balance between plasma renin activity and aldosterone. We can also see evidence of this. People with high blood pressure, regardless of their weight, tend to have higher plasma aldosterone levels. Associated with these changes are increases in left ventricular mass, urinary protein excretion, again, more commonly associated with higher aldosterone. So I think it's important that there are also evidence of higher aldosterone levels despite lower plasma renin activity in people of African heritage, people with metabolic syndrome, and again, the concerns we have of oxidative injury to the vascular beds, particularly when patients eat more salt. So I think there is this concern about the relationships of aldosterone with heart disease and kidney disease, and why anybody with resistant blood pressure probably should be considered for treatment with a mineralocorticoid receptor blocker. So appreciate that with primary aldosteronism, we have oversecretion of aldosterone pretty much independent of renin. So we would tend to have a higher aldo to renin ratio. And the two most common causes are obviously, specifically an adenoma, but also idiopathic hyperaldosteronism. The difficulty for us in clinical practice is diagnosing the latter. And the reason I say that, it's easy to get imaging if you have an adenoma to find it and remove it. But probably what is more common is bilateral idiopathic hyperaldosteronism. And there's more and more data now to indicate that this can be related to a somatic mutation that we may acquire during our lifetime. And Rick Lifton's group has nicely demonstrated actually the molecular mechanisms of that. And this, I suspect, is probably why about 20% of our patients with resistant hypertension have some defect in excess aldosterone production, which we put into a group of disorders called idiopathic hyperaldosteronism. And what's interesting is even around the world, if you look at it, it's pretty common. I gave you the 15% number earlier. Other studies obviously vary substantially from country to country, but it is common, and we need to be thinking about it. And the other point I want to make with that clinically is the greater prevalence of sleep apnea in people with drug-resistant hypertension, regardless of gender, as you can see here. AHI, shown on the right here, is the apnea hypopnea index, which obviously is much greater in individuals. This is prevalence, and this is the apnea hypopnea index in people with obstructive sleep apnea. So look at this. These are the percentage of people with obstructive sleep apnea. Contrast resistant hypertensives with, obviously, the rest of the group here. Here are males and females, hypertensive males, look at how much more common it is. So you really have to be suspicious of this and appreciate it's not necessarily just related to the size of the individual. The real measure is the resistance and obviously the correlation with the obstruction of sleep with a high apnea-hypopnea index. So the point here is you just can't look at the patient and pick it out based on the size of their neck, their body mass index, or their waist to hip ratio. It really has to be diagnosed with a sleep study. And if you give these patients CPAP, what one can see are substantial reductions in blood pressure, and that's shown here. The panel on your left is the systolic, the panel on your right is the diastolic. But look at the consistent improvements in 24-hour blood pressure, especially at night. Look at the differences here. It's dramatic. So you really need to be considerate of this. And also, take a look at the plasma aldosterone levels, dramatically higher. So these people might not only need continuous positive airway pressure, but they may also need treatment with spironolactone. And I think it may be a combination of those two things that may be the most important treatment strategy. You can see here the apnea-hypopnea index and hypoxic index correlates directly with plasma aldosterone in resistant hypertensive patients. What I just can't answer is whether or not simply giving spironolactone is enough. I don't think it is, and I think that's the biggest concern. And in addition, you can see here, if you look in normals, there is no correlation with plasma aldosterone and the apnea-hypopnea index or hypoxic index. So this is something very specific for people with obstructive sleep apnea. And you can see here another study looking at the positive relationship of sleep apnea to hyperaldosteronism. And this is a study done in an ethnically diverse population. One of the other theories that I think is worthy of considering and why the two may be interrelated is we're now realizing that visceral adiposity can lead to the production, exogenous production of aldosterone. The aldosterone causes salt and water retention, which during the course of the day ends up around your ankles. But at night, it redistributes towards your head. And obviously the concern there is, as it redistributes, it can encroach on the airway and cause swelling there and worsen, obviously, the obstructive sleep apnea. So that's kind of the theory that ties it all together. And the point I made earlier, maybe one of the strategies is simply to treat the patient with spironolactone. You can see here, in fact, there is some improvement in the apnea-hypopnea index. And again, maybe what that does is it facilitates natriuresis during the day, limits the edema. You then avoid the redistribution of the edema up around the neck later at night once you retire and go to bed in the recumbent position. So in the last part of my talk, what I'd like to do is to review with you the considerations about when to test for primary aldosteronism. Honestly, I think the major part of what you're going to see in your practice are people who are overweight, people with obstructive sleep apnea, people with probably somatic mutations where they develop hyperaldosteronism and have just diffuse adrenal hyperplasia, which you don't identify on a scan and you empirically have to treat with spironolactone. But you will have people with adenomas. They do exist. It's just not quite as common as overweight people or people with sleep disorders. So when should you test? And these are the issues that I'll review with you now: case detection testing, confirmatory testing, subtype testing, and of course treatment. And I'll leave you with a few key clinical tips. So I think when to test for primary aldosteronism is obviously anybody who has hypertension, specifically resistant hypertension, and people who have low normal or low potassiums, regardless of the presumed cause. And I think this is particularly important if they're already on a drug that blocks the renin-angiotensin system and they have a low potassium. That's a pretty good clue. And of course, the key here is the patient with treatment-resistant hypertension or severe hypertension, and individuals who you may pick up an incidental adrenal mass. Or, again, young people as well who need a complete secondary hypertension workup. And you always have to suspect hyperaldosteronism when you're doing a secondary hypertension workup. And remember, renovascular disease is not unusual, but it is unlikely to be of clinical significance unless the creatinine goes up as you lower the blood pressure. And pheochromocytoma, let's all agree, is quite rare. So what I would recommend is, for case detection testing, is a morning ambulatory paired plasma aldosterone concentration and plasma renin activity. And it may be performed while the patient's taking blood pressure medicines and without specific posture stimulation. Reduction in potassium reduces the secretion of aldosterone, and it's optimal to restore serum potassium to normal before performing diagnostic tests, and this can be done with potassium chloride. Mineralocorticoid receptor antagonists and high doses of amiloride are really the only meds that will definitely interfere and probably should be stopped at least 6 weeks before testing. However, if the patient is hypokalemic or requiring potassium supplementation while being treated with a mineralocorticoid receptor blocker, then you already know that you don't have enough receptor blockade. And case detection testing and confirmatory testing can be done while they're still on their existing dose of spironolactone or eplerenone. ACE inhibitors, ARBs, diuretics can actually elevate plasma renin activity, even in a patient with hyperaldosteronism. Therefore, in a patient being treated with one of these drugs, the finding of a detectable plasma renin activity level or a low PAC-PRA ratio does not exclude primary aldosteronism. However, when the plasma renin activity is very, very low in a patient taking an ACE, an ARB, or a diuretic, again, there are very few things that can cause that. That's probably primary hyperaldosteronism. And again, under those circumstances, then you really don't need to stop the drugs in order to do your testing. So I think that, again, the key point to remember here is that plasma renin activity is suppressed in almost all patients with hyperaldosteronism. Now, other drugs like beta blockers suppress renin activity, but also in turn suppress aldo secretion. And it's obviously to a lesser degree than renin in normal individuals. Thus, although the ratio may rise in hypertensive patients without primary aldosteronism, if you are treating the patients with beta blockers and the PAC remains less than 15, then the case defining test is not going to be significantly effective. So I don't really routinely stop beta blockers under these circumstances. So I've left you with these thoughts for step 1 in terms of when you want to start to look for it. For step 2, we talked about the morning sample, paired sample. And obviously, we discussed if your aldo ratio, aldo is over 15, or the plasma renin activity is below 1, or the ratio is over 20, you know, you pretty much have a diagnosis. And confirmatory testing is pretty easy at that point, because although it is not, an increased ratio is not diagnostic itself, you can confirm the hyperaldosteronism by demonstrating inappropriate secretion. And as long as the plasma renin activity is suppressed, most antihypertensive drugs can be used during this step, as I have previously stated, with the exception, of course, of amiloride and mineralocorticoid receptor blockers. So typically, we perform aldo suppression testing with orally administered sodium chloride and then measurement of urinary aldosterone and sodium. But if the patient, again, is spontaneously hypokalemic with a high plasma aldo concentration and a very low PRA, I don't even bother doing it. You don't need to confirm it. You have the diagnosis based on that. It's unique. So obviously, in the patient like that, you wouldn't even need to bother to do it. And in the patient with undetectable PRA, and when the 24-hour urinary sodium is over 200, and aldosterone over 12 confirms hyperaldosteronism. Now, the issue of subtype testing, I think, is another issue, because obviously, if it's unilateral, there's an opportunity for a surgical cure. And I think that's a critical question. Whereas obviously, if they have a bilateral hyperplasia, then, you know, there's not much you can do other than to treat them with spironolactone. But I have to be honest with you, in so many of my older patients where I feel I don't want to expose them to the surgical burden of treatment, I will empirically treat them with sufficient amounts of mineralocorticoid receptor blockers in order to get the potassium up into the normal level. And that should be sufficient to not only control their blood pressure, but also to protect their vascular beds from the evil effects of aldosterone. So in idiopathic hyperaldosteronism, appreciate removing one or both of the adrenal glands. It may correct the blood pressure, but, you know, you may not really be doing the patient a favor by removing both of their adrenal glands. I mean, the reality is they need to be treated medically. You know, on the other hand, if you have an adenoma and you clearly can identify one side where there is greater production, then you may want to try for a surgical cure if they are an appropriate candidate. But remember, as you go through this effort, most of these patients are normokalemic. Now, there are some nice studies that have been done about adrenal vein sampling. And there's a nice report from the Mayo Clinic which shows a very high success rate if you can see a difference. Appreciate that there are a lot of problems with CT imaging, though. About a quarter of patients would have been bypassed for surgery, and a quarter would have had unnecessary surgery. So what that really tells you is the accuracy of a CT scan is very poor. And the bottom line is, don't rely on it. If you do an adrenal CT scan and you have a hypotense nodule over 1 centimeter and they're under 40, then you might want to consider removal. But if they're over 40, then it may be smarter to obviously do adrenal vein sampling to make absolutely sure. And of course, if they're not a surgical candidate, we have mineralocorticoid receptor blockers. But again, more often than not, you may have these atypical findings of nothing or some micronodularity. And if you're still thinking about surgery, you have to do adrenal vein sampling. If you don't have lateralization, you go on to pharmacological therapy. There's nothing else you can do. So appreciate that there are different strategies here for subtype testing, but more often than not, I don't think you're going to find that you're going to be able to have a surgical cure. Just remember, you need adrenal vein sampling. You can't rely on imaging. Forget about the imaging. So again, the real goal of treatment here is to prevent morbidity and mortality. Normalization of the blood pressure is not the only goal. Normalization of blood pressure and serum potassium is really the best opportunity. And this should be the critical management plan. You can assume that as the blood pressure goes down and the potassium rises into the normal range, that you're probably on the right dose of the mineralocorticoid receptor blocker. And I've seen patients need anywhere from 25 milligrams up to 400 milligrams or even 500 milligrams of spironolactone in order to get sufficient blockade. So again, remember, if you have an adenoma, you can remove it. That's fine. Or you can treat it pharmacologically. But you have to use drugs that are specific mineralocorticoid receptor antagonists. On the other hand, if you have idiopathic or exogenous production, as might occur in a patient with a lot of visceral adiposity and metabolic syndrome, you're going to be left with specifically treating with other antihypertensive therapies, including the mineralocorticoid receptor blockers. But one other quick word. Don't forget about people who have problems with ENaC, where you specifically need to have treatments with amiloride. About 95% of the problems with somatic mutations affects, obviously, aldosterone production. But there are also going to be patients, they're very unusual, but if they don't respond to very high-dose aldosterone blockade, and they are taking the medicines, do consider amiloride as an alternate strategy to target the sodium channel and to block it. But again, the main purpose here of treatment is to avoid cardiovascular toxicity. So I've reviewed a number of these steps with you today about when to test. We've looked at case detection testing. We've looked at confirmatory testing if it's needed. And often you won't even need to do it. And we've talked about subtype testing, where again, the imaging is not ideal. And really, you need adrenal vein sampling. And this, I think, is the critical factor to remember if you're going to pursue that route. So obviously, we want to prevent morbidity and mortality, and this is going to require normalization of blood pressure and the serum potassium. And again, to avoid CV toxicity. So this is my last graphic. These were our learning objectives from my brief discussion with you today. Please consider both adrenal gland production as well as visceral adiposity as critical factors for aldosterone production, which likely explains the vast majority of resistant hypertension that we see in practice. But remember also, do a good secondary hypertension workup and make sure patients are on the right drugs and they're compliant with them. Estuti.